Hi, everyone. We're going to get our 9:30 session started. Welcome to Lumps and Bumps and Surprises. Oh my. My name is Kate Stratmeyer, and I'm the Director for Communications and Community Outreach at the UVM Cancer Center. I am so excited to share this session with you ever since our conference co-chair, Dr. Cintolo-Gonzalez, mentioned the idea in an early planning meeting. Dr. Cintolo-Gonzalez is a surgical oncologist at the University of Vermont Medical Center, specializing in soft tissue sarcoma, melanoma, and cutaneous malignancy, breast cancer, appendiceal cancer, and endocrine tumors. Her research interests include improving screening and surveillance for melanoma and incorporating circulating biomarkers into surveillance and treatment plans. Dr. Cintolo-Gonzalez has seen many lumps and bumps in her time and is well familiar with the anxiety of incidental imaging findings. I hope you find this information empowering. Please join me in welcoming Dr. Cintolo-Gonzalez.
All right, thank you. So the idea for this talk really came up because I think you don't have to raise your hands. We don't want to, violate any confidentiality, but we can kind of think in your head, have I ever looked at my body or felt something and wondered, what is this? What should I do about it? Because I for sure have. And as someone who treats a lot of cancer, I know a lot of people get worried about different things. So I think this is something we all deal with every day. And so hopefully this will give a little bit of a framework on kind of how we work these up, how to think about it. So we're going to talk about there'll be a little bit of some upfront advice and disclaimers. Then I'm going to do a talk about some skin lesions, kind of lumps and bumps within our soft tissue. And hopefully we'll have some time to go into a little bit about incidental radiology findings, but I do want to make sure we have time for questions at the end. So my first upfront advice is if you feel something on your body or someone's asking you about it and you're not initially sure what it is, don't panic. Most of the things we find are benign, are not a cancer. And there are definitely established guidelines for working these things up, as well as specialists with expertise. So my disclaimer is that I am a surgical oncologist, so I'm a cancer surgeon. And so I am trained to think about what's sort of the more worst case scenarios, what are things that can be problems that we have to identify and treat. So in this talk, there are going to be, some more problematic lesions discussed, but I think not anything as bad as what's going on in this book. So my other advice is please don't, when you find something, whether you're a provider yourself and someone's asking you, or you find something on your body, don't ever hesitate to phone a friend. And I'll give you examples when I like to phone my friends, meaning, if you're worried, ask your doctor. If you're a provider and you're not sure what something is, there are teams of specialists, and I reach out to, my sort of multidisciplinary, meaning across specialty team all the time. All right, so let's get into skin lesions. And my other disclaimer is that I wasn't initially going to talk about skin because it's a topic that I like to phone my dermatology friends on a lot. But I know I got a lot of feedback that, things we find in our skin, that's what we see. So they can cause a lot of anxiety. And in doing a lot of skin cancer, I get asked about skin findings all the time. And if I don't know, I phone my friends. All right, so for skin, the skin, now that I do treat a lot of skin cancer, is surprisingly very complicated. So we look at our skin and it seems like one of the more boring parts of our body potentially, but in our skin there are 3 main layers. Within the most superficial layer, which seems like maybe the simplest layer, there are 5 additional layers and a whole lot of cells. And all these cell types can sometimes form benign or malignant tumors. So there can be a lot going on in the skin. So when we see lumps or bumps or things on our skin, I would say the big question, so the elephant in the room, is always, is it cancer? And so, again, the first thing is to not panic and, get help if you're not sure. And we'll go over a little bit of the more kind of concerning findings and what are the things, really that we want to be more worried about. So I'm going to go through some of the types of skin cancers and some of the lookalikes, because they're also benign things that can look very similar. And so when you see a lot of these things, often they'll be benign, not the cancer. So let's talk about basal cell. So, there's some kind of classic ways that basal cell cancer can present. So it can be kind of like a little pink papule, can be curly, can be kind of ulcerated, but there's also plenty of things that will look like that are benign. So again, this is why I say no need to initially panic. There are a lot of benign findings that can look very similar. For squamous cell cancer, and Dr. Melanie Boo is going to be giving a more in-depth talk about squamous cell cancer, also can have sort of a variety of ways that it can present. But there are some things that tend to look like it that are also benign. And I think one of the more common things is a seborrheic keratosis, which will be sort of described as almost waxy and stuck on, but can be sort of scaly. And a lot of times the seborrheic keratoses, people will be worried about that being a squamous cell cancer or a melanoma, but these are very common. We kind of all accumulate them on our body over time. And so very often, a provider can just look at it and say, no, that's a seborrheic keratosis. Same with sort of warts, those can pop up and those are viral infection and can kind of look similar, and those can, but those are benign and very treatable. So, one thing we think about as to whether or not we should worry about potentially something being a cancer is we also think about what are the risk factors. Is someone at high risk? So we should have a kind of a lower threshold to maybe look at it in biopsy versus not. And so risk factors for skin cancers across the board, and certainly for basal cell and squamous cell, are shared in many ways. So definitely we'll hear sun exposure, radiation, UV radiation is a risk factor for, so histories of burns, history of a lot of sun exposure is going to make you more worried that something could potentially be a cancer rather than benign. That kind of goes along with, age and skin type, just the ability to accumulate more damage. And then long-term immunosuppression is a very important risk factor, particularly in our organ transplant population for our skin cancers. And there's a very high risk of our squamous cell cancers in those patients. So those are things that kind of have antennas up, like this is something we should be more worried about. And there are for both basal and squamous cell, some genetic syndromes that can have an increased risk as well. With squamous cell cancers, you do want to be worried about sort of chronic wounds. So things that are not healing, this will be a theme on the skin, are always something that, again, that is kind of a flag for concern. And people can get ulcers for other reasons. So for burns, diabetic ulcers, but for any sort of ulcer that's sort of progressing, not healing, we don't want to blow that off. That's something that maybe we want to be a little more concerned about. So when we're putting together how something looks, we also can think about risk factors. So another type of cancer of the skin that can kind of have some benign lookalikes is Merkel cell carcinoma. So again, not every kind of purplish lesion on the skin is a Merkel cell, so we can get sort of benign telangiectasias, so benign sort of blood vessel tumors, and those are probably the most common thing when you see the sort of purplish reddish colored lesions. So most commonly they're going to be benign, but a Merkel cell will behave a little different. It will be a little firmer. It might start to grow. So just seeing a little lesion like the ones we have up here is not in itself a worrisome feature, but certainly if it's something new, something's growing, something is getting a little more firm, that's when you start to worry a bit more. Similar risk factors to our other skin cancers, with immunosuppression being a pretty high one on risk factors for Merkel cell, but the usual suspects of kind of UV, sun exposure, radiation exposure, skin type, and age. And then there's a very, the subset of these will be associated with a particular viral infection that probably is a pretty endemic viral infection, but probably when combined with immunosuppression can help facilitate these growing. All right, and then one of the more worrisome cancers on the skin would be melanoma. And of course, many of us will have, benign moles or nevi, so pigmented lesions. And again, not all pigmented lesions are going to be cancer. So, we can't always biopsy, who wants to get biopsied on every single thing on our skin. But the classic features that I think we get a lot of education about are A, B, C, D, E. Keep it easy. So our asymmetric pigmented lesions, irregular border, variation in color, the larger it gets, so you get a little more concerned, and if it's evolving. So again, just like with the other cancers, things that are kind of growing, changing, tend to be more of concern than something that's just hanging out, staying the same. So you may ask, and this is one of those disclaimers, those kind of more concerning things. What about an amelanotic melanoma? And those, don't look like that classic ABCDE. So they're pretty low percent of melanomas, 2 to 8%. But obviously these can be a little harder to recognize. I'd say a lot of times these get removed. People are thinking more about basal or squamous cell and say, oh, it's a melanoma. But again, following those sort of guidelines of something that this is new, this is kind of changing. And again, we'll review some of those features as well. Would be something that could kind of make you more aware to biopsy something like this. And then again, risk factors for melanoma go along with our other skin cancers, with UV exposure being very high, having a lot of kind of atypical moles, and then family history. And again, there are some genetic syndromes where there is an associated increased risk for melanoma. So for these lesions, when should you biopsy them? So I would say if you come to my office, I am a surgeon and you might be more likely to get a biopsy. And so again, I try to sort of think about those high risk features, and the way that I will usually biopsy a lesion of concern will either be a punch biopsy, which is sort of like a little hole punch where we numb up the skin and take a full thickness through it, so that if it's a melanoma, we do see the depth, or I'll tend to kind of remove things because again, I'm a surgeon. But sometimes it's not clear that it definitely needs a biopsy. And again, this is when I like to have a dermatologist's eyes on things, because they're very experienced in looking head to toe. They have, a little bit better pattern recognition than someone who's not doing that all day. And then they also can add in the tool of dermoscopy. And there are some, I know, primary care providers as well that are trained in dermoscopy, where they can just take a look at the skin lesion a different way and get some additional information as to whether it looks benign or requires a biopsy. So what warrants a biopsy? Well, as we saw, if it looks like a cancer, it might not be a cancer. There's a lot of overlap. So again, that's why you don't really necessarily have to panic when you see something, but there are concerning features that will say, this needs further evaluation by a specialist. This might need a biopsy. So again, as we said, things that are growing, changing, seeming like they're kind of progressing, those should not be left alone. If it's kind of has a classic look for melanoma, sometimes it's not. Sometimes it's just a very atypical mole, but those are anything with those ABCDE features should probably be biopsied. Things that are irritating, itching, burning, that is something that I think should be removed. It doesn't mean it's a cancer. Certainly, warts can be irritating. When seborrheic keratosis erupts on the skin, it can be irritating, and they can get irritated if they're in certain areas, like where the strap of, a bag is, definitely along the bra line, the belt line. So sometimes the seborrheic keratoses will get irritated. You're concerned it could be a cancer and it's just bothering you. Those are good reasons to take it off. And anything, again, that's really not healing, something that's kind of bleeding but doesn't heal. Our bodies have incredible ability to heal. So something that's not makes me a little worrisome, because cancer does not. And then you also, if someone who has high risk factors there'll be a lower threshold to biopsy. All right. So now we'll talk about our soft tissue lumps. And when I'm talking about soft tissue, now we're kind of going below the skin into our subcutaneous tissue, which is made, predominantly of fat, but has, nerves and blood vessels and other forms of connective tissue running through it. Then there are various layers in our body. It's kind of a denser fibrous tissue called fascia, and below kind of those layers, muscle. So that's really what we're talking about. So again, when you feel a lump or a bump in the body, you want to know, you're thinking, could this be cancer, or is this just one of those benign lumps? So sort of reassuring findings, things that are small, soft, like this puppy, a more superficial location. So when it's up kind of in the subcutaneous tissue towards the fat, that tends to be less concerning than deep. You can move it, and if it's sort of been there and it's been stable for a long time. but it's more concerning if it's larger. And a lot of times we'll kind of use a 5 centimeter cutoff, but there's some leeway, something that's very soft, that maybe 6 centimeters, I might not get too worked up about. When it's below the fascia, again, I'm always concerned that could be something. It's not always. There are benign tumors in the muscle, like lipoma. I don't know if anyone recognizes this from the original Never Ending Story. It scared me a lot as a kid. So sorry, I'll move it along quickly. Any interval growth, if something was excised and it was thought to be benign, but it comes back, you have to question whether that was benign. So that also is something I worry about, and it's something that kind of doesn't move. If I'm going to just move along because that is scary. For something that doesn't move, if it's in the muscle, it's not going to move as much as when it's in the more superficial fat. So, that doesn't necessarily worry me. I like to just kind of feel that something's moving, but it does tell you it's deeper. And if you really can't move something, and it's really sticky, that's a little more concerning. So lots of things can be benign in the soft tissue. So you can have infections such as abscess, although often those will be painful and maybe even have some redness of the skin or fevers. Hernia, that's when something from one part of the body sort of makes its way into another compartment, and often that can kind of get pushed back in, and you might feel a defect, usually not fibrous covering throughout our body, the fascia. Hematoma is a blood collection that can happen after trauma, and fat necrosis also is something that can happen after trauma where the blood supply to the fat gets disrupted. And so that fat sort of dies a little bit and gets hardened. And sometimes it will even calcify and really feel hard, like a firm mass. So that can feel kind of scary, but is something we see sometimes after trauma. I'll get into lymph nodes in more detail. It's a very common thing we see are sebaceous cysts. Sometimes you see them more in the skin, but they're often right below the skin. Sometimes they'll get inflamed and get infected and drain, and other times they won't. And they pretty classically just sit under the skin on ultrasound. Lipoma is very common. I'll show you an ultrasound picture of that. That's going to be soft, often the subcutaneous tissue. I think all of us have them. If we search up and down, we'll find little fatty tumors. They're really soft. They're mobile. They can get quite big though. And then intramuscular myxoma is a benign tumor that is in the muscle. And I'll go into desmoid in a little more detail. Malignant things can be, again, things that have spread to the soft tissue from other cancers, and that's a very common way that melanoma can behave. This DFSP is not always malignant in its behavior, but it can be locally aggressive, and there's just a subtype where a small percent can behave badly. And then our connective tissue, like all cells in the body, can form cancers, and those are called soft tissue sarcomas. So when should we image these tumors? So certainly if it's going to affect our management, I'll want to get some more pictures of it. So definitely if it's going to affect how I biopsy something. So I have a low threshold to get pictures. And then how. So kind of by the book, for soft tissue lesions, we do prefer MRIs. MRIs are preferred. But I do think ultrasound also has a lot of value as a preliminary look. So let's talk about that. So ultrasound, easy to obtain, it's fast, it's cheap. So let's go into those deductibles. And I think it gives a lot of information, especially for people who are comfortable with ultrasound. And we're fortunate here in our surgical oncology department to have ultrasound right in our office. So you can really tell is it solid or cystic. So cysts, benign, we generally don't worry about those. We can tell if it's sort of fat composition like the lipoma. So you can see that there's a nice encapsulated little lesion with like the little hash marks around it, but it's about the same gray shade, not exactly, but it's close to the fat next to it. So that's very classic for lipoma. I don't need an MRI on that. And you can also sometimes tell you if there's vascular involvement or vascular structure nearby, but it is a little more limited in terms of telling you about solid masses. So that last darker mass that's not fat composition, it's a little harder to tell what that might be. And I think once you start to get below the muscle, it's a little harder to see. MRIs are great. They give you a lot of information about what's the composition potentially of the tumor. They can give you really good anatomic localization in the soft tissue, not preferred in the belly, but in the, like when you're in the visceral organs, but in your muscles, it can really tell you exactly where it is. But it's very expensive. It's longer to obtain, and it's really not well tolerated by anyone. So if anyone has had it, it's just not anyone's favorite time of day to be in a small tube for 45 minutes with a lot of banging for anyone who's had one. And so people with claustrophobia really have trouble tolerating it, and it's not necessarily enjoyable. So when should you biopsy these? I think about that 5 centimeter as kind of a flag, but for very classic lipomas, you can maybe have a little leeway in the subcutaneous tissue. Over 10, you get a biopsy. I biopsy everything that's under the fascia within the muscle, just because a higher percentage of those will be a cancer. And then if there's kind of growing, recurring lesions, things on imaging features that don't look, regular, and if I think it's really going to change what I do. So how to biopsy? Sorry, my animations are a little off because I was going between different computers. So can I just do a little tiny needle, a fine needle? And fine needles are great. They're just the size of the needle that you would use to draw blood. So they're very small. It's not really ideal for most soft tissue masses. And you can't often do as much staining as we need to distinguish some of the things that will crop up in the soft tissue, with some exceptions. So it's definitely the go-to for neck masses, or if I'm really worried that a nodule or it's a nodule or a lymph node that's a metastatic cancer. So if there's a clinical history that makes me worried, then an FNA is great. But when it's sort of a primary tumor of the soft tissue, like it's just kind of cropping up, it's like looking at the building blocks rather than the final product. So you're going to get a lot more information from a core. All right. Question, if there are any surgeons in the audience, can I just cut the lesion out? My question, can I just do an excision, one and done? So yeah, if it's something small, if it's superficial, sometimes doing the excisional biopsy both diagnoses and treats it. So it's not off the table, but you have to be able to re-excise it if there's a surprise cancer diagnosis and you need wider margins. So as long as you won't burn any bridges, then an excisional biopsy is a-okay. So the preferred method, though, because often that's not possible, is a core biopsy. So just doing a little bit of a bigger needle biopsy. If that's not technically feasible, you can cut down on the tumor and do an incisional. For any biopsies that are done on soft tissue lesions, they have to be along a planned resection, because if you do get a diagnosis of cancer, for some of these tumors, there's risk of seeding. That's not really a thing in breast. People ask me about that all the time, but for the soft tissues, some of them are. So you want to say, if I have to cut this out, where is it going to be, and can I excise that biopsy tract? On the extremities, that needs to be along the longitudinal axis. So, if you're cutting something out or doing an excisional biopsy, or that's being done to you, along the longitudinal axis of the legs or arms, not across. And the reason is because if it comes back as a cancer, it's just so much easier to re-excise, and you're still more likely to get a nice re-excision without needing to do like a skin graft. So that's just something to be aware that that's very standard. All right. See. All right, I'm going to talk about a few of the some special cases in soft tissue. So one is desmoid tumors, and I put it in benign because it's benign, but then that begs the question, why is there Cancer Network guidelines on it? And the reason is because while it's not a cancer, meaning it doesn't spread to other parts of the body, it can be really locally aggressive. And so it does have to be treated a little more aggressively than other benign tumors. But it is rare. We see it a lot, I see it a lot in the rectus musculature, but it can really be throughout the body. So there's one, this is an example of one kind of up in some of the musculature around the shoulder, and it can be in the belly too. Often they just pop up for no reason. We don't know why. There is some trends that have been observed with pregnancy as well as prior trauma, but this is not well understood, though we do know that patients with the familial adenomatous polyposis gene mutation, which is typically recognized for its colorectal cancer risk, there is an association with these, particularly in the belly. So anyone who has an intra-abdominal desmoid, we're usually going to be thinking about that as a risk factor. Usually we'll need to do a biopsy. Sometimes some of the ones in the abdomen, particularly in a patient with FAP, we don't necessarily have to biopsy. They can behave really very variably, all the things, they could progress, they could stay the same, they could, keep growing. And so we have a lot of different management. It used to be that we cut them all out. We just did surgery. But, even with surgical resection with negative margins, some will come back. And then some get resected and their margins are not negative and they don't come back. So surgical resection is used for many, particularly when they're growing, when they're asymptomatic, when it can be removed without causing a lot of problems for the patient. But we have other options too, which can be just observing them. Sometimes we can add in radiation therapy for some of them. And then there are now systemic therapies that work well and are often used for the ones in the belly, because those resections can sometimes also require removing a lot of intestines. So we'll often start with trying to sort of shrink them down and watch them. For lumps in the neck, there's a bunch of different things that can kind of crop up in the neck. So lymph nodes live in the neck, the thyroid lives in the neck, the salivary glands live up in the neck. There's tumors that can form around the carotids, and there's definitely some congenital cysts that can also form. So those are special examples in the neck. For the neck, we actually like to start with ultrasound. And that can usually give all the information that's needed. If anything more is needed, then you can think about adding your axial images, which is CT or MRI. And that usually would be done kind of by a specialist in the field if they needed something. So an ENT or an endocrine surgeon, depending on what you're dealing with. For most things in the neck, we actually don't need to do a core. So lymph nodes, when we're trying to rule out metastatic disease, and FNA is great. And for your salivary glands and your thyroid gland, you get sufficient information with a fine needle, and you don't really get a whole lot from a core. Often you're getting enough information by FNA to know if you have to take it out or not. So we don't, in the neck, less likely to be getting a big needle. And don't biopsy carotid body tumors. Those are vascular, but you can tell by ultrasound, because you can look at that blood flow. So that's just, a good thing to know. So lymph nodes, this is a common lump we all feel, because every time we get a cough or a cold, we get some swollen glands. So I thought this was useful to talk about. So these are little small immune organs that are throughout our body. We have a whole, system of lymphatic channels that are taking fluid back from our tissues. They kind of bring it back into the veins so it can go into our circulation. And throughout our body, we have kind of concentrations of these. And I say they can be deep, but there's a bunch of superficial places where we feel them. So the neck, very commonly, under the arms, in the groin. I see a lot at the bendy places. So you can also have them kind of where your elbow bends, where your knee bends. So they're at the kind of bendy places, often ticklish as well. And so that's where you may feel a lump that turns out to be a biopsy. So what causes it? I divide swollen lymph nodes into 3 categories of causes. One is infection. Anyone who's had a cold knows that that's true. Inflammation, that's not related to infection, as well as cancer, which is, of course, again, the elephant in the room is a cancer. So infectious causes can be viruses, bacteria, and fungal. So when I'm trying to assess a node for this, we sort of do stains for a whole bunch of things, but I've listed some of the more common diseases that will cause lymphadenopathy, but it can obviously be more than this. And some of the fungal can really mimic a cancer, but you can see them on your biopsy. And sometimes I've diagnosed TB and fungal also on FNA. So sometimes the FNA will diagnose that. Non-inflammatory causes, if someone's getting over an infection, the lymphadenopathy can stay longer than the infection. Autoimmune disorders, we've definitely seen after vaccination, and that was common with a lot of the COVID vaccines. And then Castleman's disease is kind of an in-between. I just put it here because it's not definitely a cancer. It is probably more we call lymphoproliferative, but not necessarily a cancer. All right. Cancer is obviously what we're worried about. So 2 causes I think of is it could be cancer that is spread from somewhere else to the lymph node. This is more common if it's an isolated lymph nodes or sort of just one lymph node or one area swelling, makes me more worried. Certainly if there's a history of cancer, someone had a cancer that could go to this, especially I think about what are the structures nearby where there could have been a cancer. And if there are risk factors for that or a history, then we're more worried about that. If, for lymphoma, that's going to be usually more diffuse, multiple lymph nodes. It's very rarely just one lymph node. And sometimes there can be associated symptoms such as fevers, chills, sweats, and fatigue. Not always. I'd say the most common symptom I see when people get sent to me for a biopsy from my hem-onc colleagues is fatigue, but sometimes not. And if you see, a lot of these symptoms overlap with infection and your inflammatory diseases, so it can be really hard to know. So we'll often ultrasound first. Ultrasound's a great choice for lymph nodes. Your normal appearing lymph nodes are going to be oval. They're going to have a little white center and a black, so that's called hypo and hyperechoic. So black on the outside, that's denser tissue, and then a fatty hilum on the inside that shows up as white on the on your ultrasound, so have a little targetoid appearance. I don't get worried about size of nodes. I worry more about just how does it look. So this other example is, round, not oval, no fatty hilum. That's a concerning lymph node. For that lymph node, if we're worried about cancer that spread, we'll do a fine needle biopsy. And so this is an example of a fine needle biopsy. You're looking for the pathologist, the cytopathologist, looking for little blue cells, which are lymphocytes that are supposed to be there, but when they see these other big cells, those are not supposed to be there. So this is an example of metastatic melanoma. When we're not dealing with a concern for metastases, we're dealing with more diffuse, and we're not sure, is this infectious? Is this inflammatory? Could this be lymphoma? We often do have to do a full excision of the lymph node. So that's when you're meeting with your surgeon to remove a whole lymph node to really be able to distinguish that. The needle biopsies tend to not give enough information. And if it is lymphoma, the hematologists generally are going to need all that tissue to run their test to know how to treat it. All right, one last special case is our breast masses, and this could be a whole talk, so I almost didn't put it in, but I mean, that's a very common lump we feel. So I thought it was important to just bring it up, that there are a lot of benign causes of breast masses, as well as some malignant causes. But we always want to rule out malignancy. Obviously, as we get more advanced in age, if we have other risk factors such as family history, there's going to be more of a concern for malignancy, but really nothing gets blown off. We work everything up. But again, a lot of these masses are benign. So in general, and anyone who's been in my clinic for a breast complaint knows that I talk about how, everyone's breasts are sort of lumpy. So our glandular tissue, that tissue that's dedicated to producing milk during lactation, is firmer, and it sits in a bed of fat, which is soft, and ligaments that are kind of running through it. So the breast tissue is heterogeneous. It's not all the same. And then throughout a person's life, there's going to be proliferative changes and changes in the breast tissue. So one of the more common masses we feel is an area of just dense breast tissue that is maybe changing, and it will feel a little different than a cancer mass. It'll have a little bit of give to it, and it can also be seen on imaging. So, in addition to kind of wanting to know about risk factors, wanting to know about the mass, so just like with our skin and our other soft tissue lumps, things that are evolving, things that are changing, things that are firmer are going to be more concerning. And if anyone with certain risk factors are going to be more concerning. Really, for any lump, we almost always get diagnostic imaging. It's just going to be very rare. Sometimes that's just us putting an ultrasound on the mass in the office and saying, oh, it's a cyst. That's great. But most commonly, we're going to get formal breast imaging. And so that's just really standard to have a low threshold for that. And that can really tell you, is this dense glandular tissue, is there a cyst or something else? So when does a breast mass have to be biopsied? Well, there's definite radiographic criteria. And so the radiologists use an algorithm called the BIRAD scale to guide whether or not they're going to recommend a biopsy, and their threshold is low. They will follow things closely if they think it's only up to a 2% chance at something, and anything more, they're going to recommend a biopsy. For things that aren't being recommended based on radiographic findings, then we might think about if it's growing, changing, a history of cancer. So sometimes I'll biopsy something that doesn't have a radiographic correlate if there are these clinical concerns. All right, so I'll probably go for about 4 more minutes on incidental imaging findings. So I might not cover all of them. But the reason I wanted to talk about this is because some of you might be aware that with the new Cures Act, there is sort of a federal mandate that patients should get their results sort of right away. Go figure, patients should have their results. So that's a great, and that's less likely for things to get lost in the shuffle. But particularly with the current kind of online portals that most hospitals are using, that means that radiographic findings get released immediately, sometimes before you can discuss it with your provider. Same with path reports. So I think it's just good to know that there are a lot of resources and expertise, because we know that as we've been doing more imaging, there are more findings that have to be worked up. So I was going to just talk a little bit about thyroid and adrenal nodules, because those are very commonly found. If I have time, we'll talk about masses in the belly. I don't think we'll have time for that. And then I'm going to just kind of let you all know who are some of the specialists and resources that you have for working up some of these other things. So thyroid nodules, very common. I know we talked about neck masses. So we talked about lymph nodes. We're going to hone in on the thyroid. Palpable masses are not as common, but incidental imaging findings, either having had an ultrasound or a CAT scan or a PET, very common. I tell my patients, if we ultrasound everyone coming in the room, about half of you all are going to have a nodule, and most are benign, and most do not need a biopsy. Obviously, we want to know if they're symptomatic, if there's any symptoms of, an overactive thyroid hyperthyroidism, because some of the nodules can produce thyroid hormone, and sort of how it's found. There are some cancer syndromes specific with thyroid cancer, so obviously that's going to raise suspicion as well. But the choice to really look at these is ultrasound. Even if it's been found on a PET, on a scan, on an MRI, ultrasound is the best way to characterize a thyroid nodule. And the reason for this is, pre-2015, everyone with a nodule over 1 centimeter got a biopsy. It was an FNA, but it's a biopsy. It's no fun getting poked in the neck. And so most of these were benign, so clearly overly biopsying people. Both the American Thyroid Association and American College of Radiology came up with guidelines, and they largely overlap, that really tell us we match the ultrasound findings with the size, and based on the number of more concerning features, the size threshold for biopsy drops. And you'll see if you ever get an ultrasound at UVM, they use TIRADS, which is really algorithmic. I think it's very great. So that tells us when we have to biopsy, but most do not need a biopsy. And most that do need a biopsy turn out to be benign. If it was found incidentally on a PET, and I see a lot of these for patients who are undergoing surveillance for other cancers, those unfortunately always need to be biopsied. I will tell you the majority that I biopsy still are benign, even though they're FDG avid. It just means that that nodule is doing something. It's producing thyroid hormone, but those do need a biopsy. And then we don't biopsy them if they're a hot nodule, meaning they're causing hyperthyroidism. Those are generally benign, and you don't want to poke something that's putting out hormone. So anyone with hyperthyroidism will get a scan to see if a nodule is hot. We do an FNA biopsy. As I said, you don't get much more information from doing a core. And this chart just shows sort of the different what are the different ways results are reported, because it's cells being sucked out. There's really a scale that's used that tells what's the risk of cancer. So there's like, yes, it's a cancer, no, it's a cancer. And there's a few kind of in between where we can do some additional molecular testing to better suss out, is that worrisome or not? But you can see here that that 70%, the majority, are going to be in that benign category. Probably one more minute, and then I'll start to switch to I'll start to wrap up. So I won't go too far into adrenal incentalomas, which incidentally, when I first heard that term in medical school, I thought it was just like a slang, but it's the formal term for, oh, I found something on the adrenal gland. And as our CT scans have been getting better and more people are scanned with CT and MRI, we just are finding more of them. The main goal of working them up, when they're found, they do need a consult, either with a specialist or for anyone who, or if your primary care is comfortable working it up, that's fine. The main thing you want to do is really just know, is it producing hormones, or is it a cancer? And so in addition to kind of history questions about the hormonal symptoms, there's this pretty standard lab workup to rule out the different types of hormonal tumors. So there's tumors that can produce adrenaline, that needs to be ruled out, that can produce sort of cortisol, glucocorticoids, ones that produce aldosterone, that's going to raise your blood pressure. And so those are bad effects. We're supposed to be in balance. So we want to treat anything functional. And then we want to rule out a cancer. There are dedicated protocols for how to look at adrenal glands, either by CT or MRI. And then there are features that can really tell us that it's benign versus more worrisome. These do not get biopsied generally unless we think it's something that's spread from somewhere else, because, if it's hormonal, it needs to come out. If it's concerning for adrenal cortical carcinoma on imaging and labs, there is a sort of a seeding risk, so those just get treated surgically. But we do have guidelines very set guidelines on when to watch, when to get labs, when to do surgery, from society guidelines. So these are set guidelines. So I'm going to skip ahead to sort of just kind of wrap up the incidental imaging findings. There's too many for me to cover in one talk, but there are specialists. So the friends you should phone, and there are specialty guidelines for a lot of these. And so, these are just who can you call for thyroid. Your ENT colleagues, your endocrine surgeons or surgical oncologists, which often overlap, and there are set guidelines. There are set guidelines for following lung nodules, for adrenal, for renal nodules. The Urologic Society has set guidelines. And I think I didn't have my pancreatic. There are pancreatic masses and cysts that I guess didn't get in this that also have set guidelines that would be dealt with by your hepatobiliary surgeons or surgical oncology. So lots of guidelines and friends to phone when there is an incidental finding. So in conclusion, seeing, feeling, finding growths in the human body is very common. Don't panic. Most of these are benign, but certainly as you've seen, there's some sort of assessment and workup that goes into figuring that out. There are some features that are more reassuring, more concerning, that might lead to more imaging and biopsy, but there are specialists who are comfortable with workup and management, and there are set clinical guidelines for a lot of the things that we commonly find incidentally on our imaging. All right, so I'll start taking questions. Is there anyone circulating? Because yeah.
This is Joyce. Hi, thank you again. I'm a twin, and she's had lumps removed from her breast. She's religious in a cult, so I haven't seen her or known what her situation is for years, but she's still alive. I have yearly exams, but I have dense breasts. So am I a candidate for one of those new non-squeezy machines? The ones that you don't have to, but they look through. I know they're supposed to have, and I don't remember the name, excuse me, but it's out of Albany, New York. They have one of the machines.
Is it like thermography?
No,
I'm
maybe.
not sure. There are some other imaging modalities in breast, some of which are validated and some are not. So the ones that we tend to go to for breast screening in our higher risk populations. So one for screening, and I know this is about screening, but obviously we want to find lumps, right? Mammography for everyone. It's really a great test for both finding things that are forming masses and things before a mass forms. And then based on risk for breast density for patients with dense breast tissue, at least in Vermont, but in a lot of places you can supplement with a screening ultrasound. Ultrasound should not replace mammogram. It's just to find areas, it's sort of fill in the gaps in what could be missed by a mammography. And then in patients with a higher risk history, so family history, that would calculate a lifetime risk greater than 20%. Instead of the ultrasound, we recommend MRI. So a lot of that gets sort of figured out based on risk modeling and calculations, if there's been a personal history of breast cancer. So we usually, everyone gets a mammogram, usually once a year. I know there's some controversy about that, but I would say once a year mammogram, and then based on density or family history, you could add an ultrasound or MRI. I don't know as much about the non-squeezy one. Sorry.
Hi, thank you. Thyroid cancer. Okay, I had thyroid cancer and had my thyroid removed, and so did my sister. Question is the reason they found it in the first place was because I fell off a roof and they did an x-ray of my spine and they saw it on the x-ray. Okay, now if I hadn't have fallen off the roof, would they have, what would have happened? Because I wouldn't have found it.
Yeah.
What would have been signs to show me that I did have something wrong with my thyroid?
Yeah, I mean, I think if you weren't having any other imaging, you maybe would have felt it at some point. It depends on kind of what kind subtype it is. I'm gonna guess it may have been, well, I'm kind of guessing what kind it is because if it was seen on ultrasound, it maybe had calcifications in it. So that's what I'm thinking. So that type sometimes can show up in lymph nodes. Although even when it does, for thyroid cancer, fortunately, the majority of them are very slow growing, not as prone to spread, although there's a couple more aggressive subtypes that are very heavily associated with a particular gene mutation. Most of it would be that you'd feel a palpable nodule or a lymph node. Symptoms that you can get with a large nodule, aside from feeling it, can be sort of neck pressure, changes in the voice, so hoarseness, getting more scratchy in the voice, because it will press on the nerve to the vocal cord, or some people will notice when they're swallowing, what we call a little dysphagia, meaning a little bit things getting a little stuck when you're swallowing. So those are the things I always ask people with a nodule. Do you have trouble swallowing? Have you noticed voice changes? Is there some pressure on your neck? I'm glad it was found. I'm sorry you fell off the roof. I'm glad it was found.
Okay, another question. There's I think you would say a history in our family as far as different kinds of cancers. I have children that are in their 30s and early 40s. And the question would be is when should they get checked for different cancers and what ones should they get checked for?
Yeah, I mean, I think there's not really good set guidelines for thyroid cancer screening aside from particular genetic mutations. So if there's a lot of a particular cancer in the family, I think it is worthwhile to meet with a genetic counselor or genetics program. So we have the familial cancer program at UVM that does it, just to sort of, give advice on which genetic mutations should be tested for. And so a lot of the individual, so when there's a genetic mutation, then that guides, there's set guidelines of, you have this mutation, this is what we're looking for. When there isn't, it goes a lot by family history for the different types of cancer. So certainly in a lot of the cancers, I know this with colon and breast, if there were young family members, but no mutation, we'll often start screening 10 years before the youngest diagnosis, but it differs per body part a little bit. It will differ a little based on what cancers are prevalent in the family.
Yeah, because we have several different kinds of cancers that are running through.
Yeah, I think so I think the familial cancer program is a good place. I know, there's to start to see if there's any genetic mutation. For thyroid, there's not as much set guidelines, but more so there are for colorectal, there are for breast, there probably are for, I think there are for GYN oncology. And so actually there is a surveillance talk later today. So I'm gonna make a shameless plug that's gonna hopefully address some of this for higher risk. It's gonna also really address the baseline population, a good set of panelists to ask about some of the specialties such as lung, GYN cancers, et cetera. I know one of our docs, new medics, Dr. Landry, is starting more of a genetics sort of program, and we have a high risk breast program in the surgical oncology division, where often we pick up on other family history and get people plugged into specialists. But for some things, there aren't guidelines in terms of like thyroid when it's not associated with the gene mutation. So it's hard without knowing the specifics of the family history because it varies.
We have a last question.
Okay.
Yeah.
Thank you for this. So in the vein of incidental findings, 4 years ago, I was in a car crash and there was an incidental finding of a mass on my lower right lung lobe, which was subsequently misdiagnosed for 7 months by multiple medical centers, only as a benign birth defect, only to be found as a metastatic tumor from endometrial stromal sarcoma after surgical resection. So I guess this is not so much a question, but a plug for the clinicians in the room that masses on lungs, if they're found, please order other imaging rather than just because the mass in my uterus was subsequently found when the spindle cells that were uterine in origin were found with pathology after my quote unquote benign birth defect was surgically removed. So please don't write off lung tumors. Lungs are hot spots for sarcoma metastatic behavior.
Yeah, no, that is true. They're the most common place for sarcoma. And I think, I mean, unfortunately, it's a whole other talk about sort of medical errors and in the screening world. And when, we don't want to overly biopsy, overly test, overly treat, but we also never want to miss anything. And that's a tough balance. I'm sorry that you went through that. That's really hard. And I think that's where my plug on, in having a team. And so, when I have findings, especially in the soft tissue realm, and it ends up being a catch-all when we have tumors and we don't know, I think that's where the multidisciplinary team, getting lots of eyes on it. So I have a low threshold to present unusual findings if I'm not sure at our tumor boards. We have them for different sites, and I would say our sarcoma one will also look at things where should we look into this more? And I think that's where it's important for physicians to be humble and really ask for help too. So the phone a friend is not really just for patients, very much, probably more so for providers, that we have to all work together because things are difficult and it impacts people's lives for sure.
Thank you so much.
If any, I can kind of come down here to the side if anyone had any questions or wanted to talk that, couldn't get to. But I know what we're going to turn over for the next session.